this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
Dr. Graczyk. She is a current PGY2 emergency medicine pharmacy resident at Detroit Medical Center, Detroit Receiving Hospital, and she will be providing an overview of the journal article titled Impact of Administering Buprenorphine to Overdose Survivors Using Emergency Medical Services.
Hi, everyone. Thank you for the introduction. So today I'm going to be talking about buprenorphine, particularly using emergency medical services today. Some brief objectives for you all today. Let's talk about the background of this study. We'll talk about the methods. We'll review some of the results of the study, and then we'll discuss the results and then how we're going to best apply this to practice. Before I start, I want to ask you all a question. Do you guys have a buprenorphine protocol at your hospital in the ED? Do you induce buprenorphine in the ED, or do you have emergency medical services that do offer buprenorphine? Okay, we're getting some answers. A few yes, a few no, a few ED-based services. Yes, it is a very developing new thing coming into a lot of emergency medicine services, starting to have buprenorphine induction in the emergency department. So I really wanted to talk about this study too in particular because it does talk about particularly utilizing out-of-hospital services. So we'll get started. I think it's important to start about the background, of course, with the opioid epidemic. It's something that's so prevalent in our country and important to think about. It causes 200,000 ED visits per year, generally speaking, with data from 2016. It relates to so many deaths in our country, 69,000 due to opioids in 2020, leading to that one-year mortality of 5 to 10%. And medication for opioid use disorder is very effective. We can decrease our mortality by up to 67%. And medications that have shown to decrease mortality include things like buprenorphine and methadone. And something that's really notable is that treatment initiation rates among overdose survivors is so low. And this is something that why we're starting to see some of these new programs in the emergency department is try to increase those treatment initiation rates and try to hopefully decrease illicit opioid use. Something that prevents our patients potentially from reaching either some of these treatment initiation programs is actually naloxone. So naloxone, as we know, is our reversal agent for opioid overdose. It's our life-saving medication. But however, we frequently see this both in the ED and by EMS services that this is being used. But when we do use it, it does induce withdrawal and discomfort. So we have to make sure our dosing is appropriate of naloxone and everything. But it does cause nausea, vomiting. And because of that, they cause immediate craving of opioids. The naloxone will kick those opioid agonists right off the receptor and have immediate cravings. And for that reason, a lot of the time we see refusal of EMS transport for these reasons. The patients are uncomfortable, they're agitated, anxious, and sometimes even if they are transported to the hospital, they leave the hospital prior to even engaging in treatment. So for these reasons, though naloxone is a life-saving measure, it can have some of these repercussions associated with it. In terms of that, this is where buprenorphine comes into play in terms of its mechanism of action, I think is important to talk about, especially when we're thinking about introducing this into the pre-hospital setting. So buprenorphine, as a review, is our partial agonist. It has a very high binding affinity to that mu receptor. So it kicks off any full opioids that are currently bound to the mu receptor, which is important to think about. We'll talk a little bit about the inclusion criteria for this study, but it's important that if a patient is currently either did just overdose and is reversed with naloxone, you can initiate buprenorphine as that full opioid agonist would be removed from the mu receptors after naloxone. Something important to note of why buprenorphine is so preferred in the treatment of opioid use disorder is because that it has a ceiling effect. It's only a partial agonist, so it has the highest binding to that receptor, and also it has a very low risk of respiratory depression. It also has low abuse potential, and also overall that ceiling effect is why it makes it so effective. As we know, outpatient is also in combination with naloxone, so it prevents abuse deterrent that way. In terms of literature and where buprenorphine has been seen in the past in previous studies, first we have Berg and colleagues in 2007 did a retrospective chart review. They looked at simply buprenorphine versus symptomatic treatment being with things like clonidine, for example. And they looked at ED return rates within 30 days, and they ended up seeing that use with buprenorphine actually decreased rates of ED return within 30 days, which was the first study to really show buprenorphine's effect potentially being induced in the emergency department setting. Another study in 2015 was a randomized control trial. They actually looked at 3 different types of interventions. The first intervention was just a referral to an opioid use treatment center. The second intervention, they call it a brief intervention, meaning symptomatic treatment, such as with clonidine, for example, and other symptomatic relief. And the last would be brief intervention plus buprenorphine. They ended up comparing that engagement of addiction treatment by day 30, and they ended up seeing a much higher rate when buprenorphine was used in addition to symptomatic treatment when done in the emergency department. So another reason why it may be beneficial for our opioid use disorder patients. The purpose of this study, though, particularly, is evaluating if we use EMS services. So like we mentioned, out of hospital setting, can we reach more patients? Can we get patients more engaged in this treatment process? There's no current literature right now applying buprenorphine in this type of setting. So that's where this specific research comes into play. This particular institution in this particular field, they created this buprenorphine field initiation of rescue treatment by EMS. This is their protocol that they developed. So they had paramedics, and they extensively trained these paramedics. I mean, they sent them into many rounds of school. They shadowed different providers, EMS providers. They had many counseling services and types of education that way. So they were very well trained. They were also trained on naloxone administration. So they made sure that it was clear when naloxone is indicated, particularly when they're experiencing respiratory depression or arrest, and they're not giving naloxone to every single patient in some type of overdose if they're protecting their airway. And then last would be buprenorphine's indication. If those patients for an acute overdose, reverse with naloxone when it's appropriate to be giving buprenorphine if they had the capacity to be basically consenting to that administration. In terms of additional qualifiers for buprenorphine administration in this study, they also were required to have COWS score greater than 5. The COWS score is the scale that we use to assess patients' level of withdrawal. So the standard of care is that buprenorphine should be administered only when the COWS score is greater than 5, indicating a mild withdrawal. And the reason for that is just how we discussed with the mechanism of action of buprenorphine, how it can kick off those opioid agonists to that high binding affinity. So when they have a COWS score greater than 5, they're already in a slight withdrawal, and we won't send them into something called precipitated withdrawal. They were also required to be opioid free for 72 hours prior to the overdose. They were ineligible based on a few factors, but more notably, it was a provider review, or they had methadone within 48 hours and made them ineligible to be given buprenorphine. In terms of methods for this study, it was a retrospective matched cohort study. I really want to highlight that there are 2 interventions done for this study, and we're going to break down the results based on 2 of these interventions. So first would be exposure to the buprenorphine-equipped ambulance versus the non-buprenorphine-equipped ambulances. How I mentioned how they had educated those EMS providers very well and extensively, versus if the patient received buprenorphine or not when they were in the field. This was done over the course of a year, and it was looking at that out of hospital, particularly patients that were in acute overdose, and they did require naloxone for reversal. This is a breakdown of the chart of how they were able to select their patients. I want to break it down because it kind of helps clarify where they got each of their patient population groups from. They took 1,800 ALS encounters, any type of opioid overdose that required naloxone reversal. They then split that down into whether that was a buprenorphine-equipped ambulances, like the ones that were extensively trained, versus the non-buprenorphine ambulances. They broke that down even further into, on the buprenorphine side, if they received buprenorphine versus did not receive buprenorphine, and they randomized cases to those 94 patients that did receive buprenorphine through the protocol. They then went back to that non-buprenorphine group and then matched those patients based on both socioeconomic data, patient demographics, things like that, to have a very matched, clear comparison group. And then they further broke it down into the inclusion-exclusion criteria that we just went through to get buprenorphine-equipped ambulances, 117 total cases, versus on the non-buprenorphine ambulance side, 123 patients. So that's just kind of a breakdown of how we're getting these different groups. So it's a little more clear when we talk about the results of the study. In terms of primary outcome, they looked at reduction of withdrawal symptoms. They looked at that engagement in the opioid use treatment programs. They looked at subsequent overdoses at 24 hours and 7 days. In terms of secondary outcomes, they looked at if those patients accepted transport to the emergency department, if they spent time on the scene, and then how many doses of naloxone were administered by the EMS personnel. In terms of statistical analysis, they did for, again, primary analysis, we just looked at the ambulance comparison. What I mean by that is if they were buprenorphine equipped versus not, and they looked at an intent to treat analysis. So if you were a buprenorphine ambulance, they treated it as if those patients were anticipated to get buprenorphine, versus the secondary analysis being your buprenorphine comparison, whether those patients receive buprenorphine or not. In terms of results, so we're going to start off with the ambulance type comparison. So again, 117 patients in the buprenorphine equipped versus 123 in the non-buprenorphine equipped. It was majority African-American men that were included in this study from a patient population perspective. In terms of the primary outcome of opioid use treatment program engagement within 30 days, you see on the x-axis, that's your buprenorphine equipped versus non. And then on the y-axis, your percent of patients. You can clearly see there's a 20% higher engagement in opioid treatment programs after they were encountered a buprenorphine equipped ambulance, whether or not they even got buprenorphine or not. In terms of overdose within 24 hours and 7 days, there was no statistical significant difference between the two. For secondary outcomes, they actually, those patients did experience a buprenorphine equipped ambulance, they had reduced odds of transport to the hospital. They were actually also on scene about 6 minutes longer than those the regular ambulances. And then last, they actually had an increased average dose of naloxone from 2.14 milligrams to 2.51 milligrams as an average dose by any route available. In summary, just to summarize some of those comparisons between just the ambulance types, they had 20% higher engagement in opioid treatment programs at 30 days. There was no difference in overdose. They had less transport to the hospital and longer time on the scene. And they gave higher doses of naloxone of any route compared to the non-buprenorphine ambulances. Now, same outcomes, but different subset of patients. They're looking at those patients that received buprenorphine versus did not receive buprenorphine. So 74 patients versus 43. Similar patient demographics were pretty equal between the two groups. In terms of the buprenorphine group, I think it's helpful to break down to see how much buprenorphine did these patients get. So majority of patients got 16 milligrams of buprenorphine. And then I want to highlight also the COW score initially. So the average reported COW score was 9, and 9 falls into a mild withdrawal category as an initial COW score. Any COW score greater than 12 falls into a moderate withdrawal category. So I think it's interesting from that perspective that once they received buprenorphine, that COW score actually went down by 6 points to 3. And then of those patients that did receive buprenorphine and then were thus scheduled with an appointment at those opioid use treatment programs, 42% attended those scheduled appointments. From that primary outcome, again, we do see similar results to those who did receive buprenorphine, that they had a much higher engagement in opioid use treatment programs by 30 days compared to those who did not receive buprenorphine by 35% versus 9%. And that was statistically significant. In terms of overdose, again, not statistically significant finding, but you will see here those that received buprenorphine had a 1% chance of overdosing in 24 hours versus 16%. If they did not receive buprenorphine, again, not statistically significant, but notable finding. And then by 7-day overdose, there was no difference between the two either, though a little bit lower in the buprenorphine group. And for secondary outcomes, for those patients who received buprenorphine, they actually had similar transportation rates to the hospital, as opposed to those patients that in the last group, as we mentioned, in the ambulances that were equipped with buprenorphine had less rates to the hospital. In this group, they had similar rates. They were on the scene much longer, up to 10% or 10 minutes longer, and they also had more naloxone administered compared to those patients who did not receive buprenorphine in those ambulances. My first question, there was no decrease in rates of overdose. Why? And I think that's a great question. And I think some of this reason might be because, as we mentioned, 42% of those patients even went to that outpatient clinic visit. Did they receive a naloxone prescription to be filled outpatient? What if they were on long-acting opioids? What if they didn't go to the hospital and then they had a long-acting opioid and then unfortunately overdosed again within 24 hours? I think these are all big questions that I have as to potential reasons why there was no change in the rates of overdose. I don't think it can be clear, but you would think with the use of buprenorphine that potentially would go down, but it'd be helpful to see potentially outpatient refills of buprenorphine to see if those patients continued on that treatment. My second question would be, just in general, like, if the patients were given naloxone, what about the timing of buprenorphine? So these patients were required to be given naloxone to reverse their acute opioid overdose. So how long after the patient was unfortunately maybe going through some sort of withdrawal after a large dose of naloxone? They were giving an average of 2 milligrams IM of naloxone. At what point were those patients okay and aware to get the buprenorphine? What if they were on a long-acting opioid? Did they require multiple doses of naloxone? Did the buprenorphine send them into precipitated withdrawal? And the answer to that is that they did report that there was no incidence of precipitated withdrawal in the out-of-hospital setting. But it does make me wonder what if in the ED, did they have any incidence of precipitated withdrawal in the ED, again, due to long-acting opioids? I think I have a lot of questions too about the discussion in terms of efficacy of that buprenorphine for these reasons as well. The author did have some limitations as well that they identified. They identified that it does depend on the amount of naloxone that patient got. It could affect their level of involvement. The typical recommended naloxone dose IM is usually 0.8 milligrams, and these patients were receiving an average of 2 milligrams IM. So this could have completely sent off all of the opioid, bumped off all the opioid agonists off of the receptors and sent them into a much more potentially aggressive withdrawal, meaning that they might have an increased lack of motivation to participate in therapy or be transported to the hospital for the discomfort, the nausea, the vomiting, and all those reasons. It was not blinded as it was a retrospective study. It wasn't experimentally controlled. And because this was an EMS study, it was limited health information exchange since they didn't have access to all the institutions that they transported these patients to. In terms of limitations that I identified for this study, I wish I had known the initial presentation of these patients. Were they initially unresponsive, completely respiratory depression, or were they just not protecting their airway? They required naloxone, but they were just somnolent. I just would have liked to know their baseline because I think that would have affected potentially the differences between the groups and their engagement in both being transported to the hospital as well as engagement in treatment programs. Also, did all patients that receive buprenorphine get resources for follow-up and go to those appointments? Did every single patient get a follow-up appointment? I think those are things that were not clear in the results of the study, and I would like to know that. And then also, one of the inclusion criteria to receive buprenorphine was that the patient required to be opioid-free for 72 hours prior to the overdose. I would just wonder how that was able to be determined. Was that patient reported that this is their first incidence of opioid use within 72 hours? How was it able to be determined or proved? Do we take the patient's word for it? I think that was an interesting inclusion criteria as well. And then again, back to that naloxone dose appropriateness, that 2 milligram IM dose might have been a lot to potentially cause patients to not be as engaged in treatment programs. I also wonder if there's some bias with the matching. As I talked about, they handpicked these certain patients as they went through to try to match these two groups based on socioeconomic, patient demographic data to best match these groups. So it was handpicked. So I think there could be some potential for bias. In terms of strengths I identified, I think this is a very generalizable study. Particularly here, I am at Detroit Receiving Hospital, where our patient population, is generally a disproportionately low income community. So I feel like it's generalizable to us in a lot of big cities, particularly where there is high opioid use. Here in Detroit, there's a lot of heroin use. So it is useful for us to think about potentially implementing into our EMS programs. I also thought it was great that there was no exclusion criteria for co-ingestion as well. That's something that's more realistic to general EMS populations and everything, that it has the potential for patients to co-ingest and thus affect potentially their engagement in going to the hospital. And then last, I do think it was beneficial that they compared both the ambulance type and the buprenorphine type given versus not given, just because I think that it's helpful to know, okay, we trained all of these EMS personnel. Did that affect their engagement rates in outpatient treatment, or was it the buprenorphine? So I actually like that they did both comparisons there. With this in mind, the author did have some conclusions as well. So the author felt that with opioid overdose patients that encountered buprenorphine, they felt that there was a decrease in opioid withdrawal symptoms, there was an increase in outpatient addiction follow-up care, and there was no difference in repeat overdose. All of which are true, but I felt like I took something else away from this study. So I felt that opioid overdose patients who are reversed with naloxone and then given buprenorphine in the out-of-hospital setting, there were decreased ED visits for opioid use disorder. So those patients ended up going to the ED less frequently, so less transport to the hospital. And because maybe they were giving resources, maybe they were educated. So I think there's pros and cons to that statement. Whether or not they might have even needed additional care at the hospital might have been needed. So I think there's two sides to that statement, but I also see that there's a 50% attended outpatient addiction follow-up care, which I see a lot of potential for growth for that, but at least it's a start. And so I think it's beneficial to know, like, going forward, if this is something that we want to implement in our EMS services, I think it just reaches more patients. In that pre-hospital setting, patients are already denying transport to the hospital. So maybe this can just increase the amount of patients we can get access and resources to for potentially treatment of opioid use disorder to battle that opioid epidemic that we have going on. With all of this in mind, I am happy to open it up for questions from you all at this time.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.